our clinical productivity, but also our clinical practice and how we report our hernias. So as many of you know, in 2023, the American Medical Association Relative Value Utilization Committee, the RUC committee, in collaboration with the Centers of Medicare and Medicaid Services, made a major overhaul of the CPT coding process. So there were 18 CPT codes that were completely removed and replaced with the new CPT codes, a new set of 18 codes to replace the old ones. And these codes oftentimes relate to the term anterior abdominal hernia, which is an all-encompassing term that refers to all types of ventral hernia, whether it is umbilical, epigastric, incisional, spigillian, primary ventral. The only exception really is peristomal hernias, which now have two set of codes. That's a new addition, and these codes can be used in conjunction with a ventral hernia code if both hernias are being repaired simultaneously. The other thing that they looked at is these codes really relate to three hernia characteristics, whether the hernia is primary or recurrent, or initial or recurrent. It relates to the defect size and whether the hernia is reducible versus incarcerated or strangulated. What's interesting is that procedural details no longer matter. So it used to, we used to have open codes and laparoscopic codes. There were codes for the addition or implantation of mesh. That's all gone. The only thing that matters was what hernia you're treating. There's certain codes that are unchanged. Inguinal, femoral, obturator hernias, lumbar hernias still have the same codes. Importantly, the trunk, the myofascial trunk flap, the 15734 codes remains the same. That hasn't changed. And the unlisted laparoscopic hernioplasty codes, which is oftentimes used when you do a robotic abdominal wall reconstruction, these are all the same. They have not changed. The introduction of defect size into the CPT coding is a new addition that we've never done that before. And it's very important to know how to measure the size. So you basically have a length and width, and you generally use the largest of the two to code your hernia. If there are multiple defects, you just take the largest distance between the top defect and the bottom defect to give you the length, or the largest horizontal distance from right to left to give you the width. One special case is if you have two hernias that are far apart from each other, more than 10 centimeters of intact fascia in between, then you measure each defect separately and you add them up, even if the largest dimension was in a different place. So in the picture here, the right upper quadrant defect with the picture on the right upper quadrant defect is longer than wider, and then the bottom one is wider than longer. So you add the length of the first to the width of the second. The other major change is the 0-day global period. That's the new additions. Normally, we're more commonly used to the 90-day global period, where all postoperative care up to 90 days is included. However, with the new codes, there's a 0-day global period, which means that both inpatient and outpatient postoperative care are separately billable with the traditional E&M codes. So how can the QC help? Well, for people who used to use the QC prior, a lot of these data you already collect. So for in terms of my operative dictation, it really hasn't changed, but because the QC have traditionally collected whether the hernia is initial or recurrent, the defect measurements are always included in the QC. Incarceration, is not straightforward. So there's no question if the hernia is reducible versus incarcerated. But since the QC has adopted a new vendor as of 2024, we are collecting CPT codes. So that's a way to get that incarceration data. Also, if there's bowel obstruction, that's also captured. The QC captures peristomal hernias. And another new code is explantation of non-infected mesh. That's also something that the QC helps. But the QC is a quality collaborative. It's not really a coding platform. Its goals is not really to improve optimization, but there's some overlap between the two processes, and that can help us in terms of how we think about hernias and how to document things so that you can get your proper reimbursement. But the other thing that the QC can help is it can function as a platform for research that can answer some clinical questions related to the CPT coding process, particularly when it comes to clinical productivity, but also the clinical practice and reporting. So I'm going to start with the clinical productivity. So when the new codes started, I was very nervous, to be honest with you. I mean, you go on social media and you see surgeons posting some comparative tables between the old RVU system versus the new RVU system. At that time, I was going up for academic promotion, and your clinical productivity is important as a primarily clinical faculty. Also, we had a new compensation plan, so all of that was weighing on me, and I was really nervous about this coding change. And I felt that it's really imperative that we answer the question, are the new codes going to impact the RVUs, particularly negatively? So that's basically where the study that we published earlier this year came from. What's the impact of the CPT codes on work RVUs? So I pulled up my own data from the QC, and I had 316 ventral hernia repairs. I included lumbar and flank hernias and some concomitant procedures just to simplify the math. And I ended up with 143 subjects who underwent ventral hernia repair. And then I took these cases and I coded them twice. The first time using the old CPT codes and the second time using the new CPT codes, and then just calculated the RVUs and compared them. And this is just the most simplistic of the answer, is that the median RVU per case was about 13.8 using the previous CPT codes and 14.1 using the new system. So there's a very small difference of 0.3. It was clinically, statistically significant, but really, in reality, 0.3 RVUs mean nothing. The other thing that is important is I wanted to know, using the new codes, how much does the post-operative care really matter? And it does capture about 9% of the total RVU. So it's very, very important to make sure that you recognize these patients and you actually capture these post-operative visits. So the CPT coding update did have a small impact, very small impact on clinical productivity, was really reassuring. If anything, slightly positive impact. But there's a big caveat here. This is not the whole story, right? So RVUs don't tell the whole pictures. Surgeon compensation is not always directly related to RVUs. There are professional fees, there are facility fees, and oftentimes surgeons are facing really harsh time with pay cuts that is not captured by the study. So I really don't want anybody to feel that this is disregarding any of the pain that a lot of surgeons really feel that seem to coincide with the CPT coding change. So the other important research question that the QC helped us answer is, a lot of people were thinking, well, now we're not going to see 2.5 centimeter defects anymore, right? Surgeon is going to start reporting things differently. We may change the way we practice. I was concerned, particularly, are we going to see more open surgery? Because laparoscopic surgery using the old system, generally, I would say, for ventrals, give you a bump in your RVUs. Compared to open surgery. So is that going to change anything in terms of the way we practice hernia surgery? And this is a study that is currently under review. It's not published, hasn't been peer reviewed, so please keep that in mind. This is a project of the ACHQC Research Committee. The lead author on this is Chris Schneider, who's not here today, but I got this data from him that he gladly shared. So we looked at ventral hernia repairs from the QC that were performed in 2022 and compared them to 2023. And we had, I would say, about 5,000 patients in each arm. And then we looked at certain things just to comparison, head-to-head, just percentages. There was a similar proportion of recurrent hernias, so we're not reporting more recurrent hernia in 2023. There's a drop in the open approach in 2023. So it's about 4% to drop. And it's really hard to tell if this is just a coincidence because there have been a trend. There's another study that was presented at the QC meeting that showed year after year, we're doing less open surgery and more MIS repair. So I think this is probably related to that. Mesh use was not changed. But what's interesting is looking at the defect measurements. So if you look at the median defect width was pretty much the same. But if you looked at the three categories, less than 3, it had dropped by 4%. Not a huge drop. You can see more change on the defect length down below. So again, the median defect length is being reported 1 centimeter more. And if you look at the less than 3 centimeters at the bottom portion of the table, 45% versus 38%. So in conclusion, it's very important to understand the coding process to make sure that you're in compliance and you're actually capturing your proper reimbursement. The QC collects a lot of the coding variables, although it's not directly related to the coding. The new codes have a modest impact on clinical productivity. And surgeons are reporting some increase in defect sizes, not a lot. And we don't know why that is. Is it just basically that we're more likely to round up? Or is it that we're being more vigilant about actually measuring the defect, where in the past maybe we've been kind of eyeballing it? So we just don't know. So questions at the end? Okay, well, thank you very much, and I welcome your questions later.
Okay, next up is Dr. Petro. He will be talking to us about long-term results of a randomized control trial comparing open retromuscular keyhole versus Sugar-Baker peristomal hernia repairs with synthetic mesh.
Thank you so much. I appreciate the opportunity to present. This was a ton of work over about the course of 5 years, and we finally finished it up, and it was actually just published this morning in JAMA Surgery. So, thank you. So let's go through it. So these are my disclosures. So most of the peristomal hernias we see have a concomitant midline or need their stoma moved or revised. And so that's why for most peristomal hernias, we do approach them in an open retromuscular manner. When you do that, you have to put the bow through the abdominal wall in one of two configurations. You either line up all the holes in the posterior anterior fascia and make a hole in the mesh, or you offset the holes in the posterior and anterior sheath and drape the bow over the lateral edge of the mesh, and that's called a retromuscular Sugar-Baker technique. When we initially studied this, we had about an 8% erosion rate. And so we kind of held off and pumped the brakes on it for a while. But when we did a post hoc analysis of our biologic synthetic data, we found almost a 20% recurrence difference favoring the Sugar-Baker technique. And so we kind of had an epiphany of, well, maybe if we stop fixating the mesh, the erosions will go away. And that kind of anecdotally seemed to be the case. And so once we addressed the erosion issue, we thought, okay, now it's time to put this to the test and see if at 2 years, we actually would reduce recurrence rates with the retromuscular Sugar-Baker compared to the keyhole technique. Obviously, we would look at all the other typical secondary outcomes. I partnered with Neil Smart at this point to look at some stoma-specific quality of life tools, and he recommended also using this decision regret tool, which I love. It puts decision regret on a scale of 0 to 100 using 5 simple questions. I actually think it should be the primary outcome of everything that we do. It's a decision regret of should have had the operation or not. These are the inclusion and exclusion criteria. And so these are, patients undergoing open retromuscular repair. We did exclude patients with a continent urostomy that they had to catheterize, or intraoperatively, if the patient didn't have enough length of bowel to do a Sugar-Baker, then they wouldn't be able to be randomized and they were excluded. Again, for keyhole repairs, we preferred it to take the bowel down and bring it through a cruciate incision in the mesh instead of doing a lateral slit in the mesh and sewing the tails together. You were allowed to do either, but again, our preference was to do a cruciate incision. And then for a Sugar-Baker, if possible, we would try to keep the bowel up in place, not take it down, and get as much lateral as possible for overlap. Again, for both of these, minimal or no mesh fixation. These are our outcomes. And so we were powered to detect a 20% difference in peristomal hernia recurrence rate at 2 years. This took us up to 150 patients. For recurrence was defined as omentum or a separate piece of bowel herniating through the stoma site. And that was determined by 2 out of 3 blinded reviewers reviewing the CT scan. Okay. Pain was by the PROMIS score. We used the colostomy impact score, which is what Neil recommended for the stoma-specific quality of life. We used Hercules, and then obviously, like I just said, the decision regret score. This is our publication. So we assessed 202 patients. The most common reason for intraoperative exclusion was you didn't have enough length of the bowel. And the most common reason for patients not being enrolled is that the patients didn't want to participate. The groups were comparable in terms of their comorbidities, and most of the hernia characteristics were pretty similar as well. Usually, typically, randomization takes care of this. Now, this gets to be a little confusing, and when we present this, when we have presented this before, has been often cited as one of the limitations of the study, and I would just like to take a moment to explain that and challenge it. So for a keyhole, like I said, the preference is to take it down and to bring it back up through a cruciate incision. Okay. And so because we're taking it down, if you're going to recite it, that would be, optional at that point. And some people would say that reciting it at a new location is not really fixing the peristomal hernia. It's prophylactic reinforcement at that point. As opposed to a sugar baker, which if you leave it in situ and don't take it down, then you're fixing the hernia, and that would potentially put the sugar baker technique at a disadvantage. I would push back and say that most proponents of the sugar baker technique argue that that's an advantage of that technique, is that you don't have to take the stoma down. So it can't be both an advantage and a disadvantage to take the stoma down. And I think that this is very pragmatic in the sense of, if you knew one technique was better and you were going to do employ that technique, that's what you would do. So that's kind of our justification. Because the keyholes were more likely to be taken down and brought back up, their wound class was more likely to be a CDC3 than a 2. So in our 30-day outcomes, the only difference that we found, and it wasn't statistically different, but there's, certainly it raised an eyebrow, was the 4 stoma-related complications that were related to tension at the mesh stoma interface for the sugar baker technique. One was stoma necrosis, one was obstruction, one was early post-op recurrence requiring reoperation, and a mucocutaneous separation. So all of these were related to tension at the mesh stoma interface. We had none in the keyhole technique. There were no difference in the patient-reported outcomes early on. But what about the 2-year results? And so in terms of follow-up, so we had 68% clinical follow-up at 2 years, but a lot of people had recurred, unfortunately. About 12% had recurred before 2 years. And so at least we had clinical definitive follow-up for the primary outcome of over 80% of the patients at 2 years. And then we had PROs for another good chunk of them. So we really only lost 3 patients. What about the recurrence? So after we were done randomizing and everyone was enrolled and randomizations were done, we couldn't help ourselves. We peaked at the 1-year data, and we really thought we had something at 1 year. And there's no doubt that the sugar baker delayed recurrence at 1 year, but by the 2nd year caught up. And so what we learned here was that if you got a keyhole and it's going to recur, it's probably going to recur early, and the sugar bakers just need a little time to catch up. And our Kaplan-Meier curve is consistent with that. In terms of, we had a pre-specified multivariate analysis looking at all the other things that might be related to recurrence. So ostomy relocation that we mentioned before, rematuring at the same location, ileostomy versus colostomy, and nothing really panned out. I think BMI was the closest thing to being statistically significant, but even that was not. Again, 150 peristomal patients is a lot to anyone that's operating, but from a statistics standpoint, that's not that many. For reoperations, more likely to get a reoperation for recurrence, for a keyhole, again, and for other reasons as well, not related to stoma, but not statistically significant, probably underpowered to detect that difference. Wound morbidity, no huge difference between the 2 groups. Patient-reported outcomes are incredibly important here, because you can argue that our definition of a recurrence, meaning the omentum or a separate piece of bowel coming through the aperture, isn't really, you can have a redundant loop of bowel and a bulge, and well, maybe that, is actually important. And so there could be maybe a subclinical difference that wasn't picked up by our CT scan review. So the PROs here are important. We might have found a signal between the 2, but we didn't. The colostomy impact scores were pretty similar between the 2 groups. Again, understanding that there is a small difference even in the recurrence rates, but that didn't pan out from a PRO standpoint. Hercules quality of life. I think what's interesting from Hercules and from the PROMIS scores is how much people improve from 1 year to the 2nd year. And so it's almost like they have PTSD and they think that it's going to come back, and it's not until the second year do they actually believe that it's truly gone, and maybe they're home free. Decision regret, this scale is on a 0 to 100. And so these scores are actually quite low in terms of a decision regret standpoint. So at 2 years, the open retromuscular Sugar-Baker technique does delay, but not reduce peristomal hernia recurrence compared to a keyhole mesh technique. There's no difference in PROs, no difference in wound morbidity. This is kind of, in terms of exploratory questions, it does seem like, there's a difference in potential reoperations for recurrence. And so as we get our 3, 4, and 5-year outcomes, this is something we're going to be keeping a close eye on to see if it's, converging or diverging, or just going to stay the same. So I think, there's something here for everyone, really. If you believe in the Sugar-Baker technique, I think there's no doubt, if you have enough length of bowel and you're skilled in the technique and you know how to do it, there's not necessarily reason not to do it. I think that, again, it'll, if nothing else, it certainly delays recurrence. But I think the biggest takeaway is if I don't have the length and I'm not, the person's abdominal wall is really thick, I'm not going to force it. There's no reason to force a retromuscular Sugar-Baker just to say you did it, because a keyhole, as we saw from the data, is not that dramatically different, particularly from a PRO standpoint. The other thing that we're working on right now, and I'll just mention since I got a couple minutes left, is we are breaking down the classification, looking at not just the recurrence the dramatic recurrences that we described, but the patients that have a bulge or no bulge at all. Does the width of the bulge or the width of the aperture, how does that correlate with the PROs? And so that'll be the next thing from our group on this. We'll do a post.
And I've had the privilege of working with a great team on the opioid reduction task force for the last 6 years. And I have no disclosures. I want to start this with an interactive slide. I'm going to show you this slide right now, and I want you to think about your own prescribing before we get into the talk. And if you think about those of you who do ambulatory inguinal hernia repair, how many tablets do you send your patients home with if you're not participating in a prospective randomized clinical trial that I'll mention in a minute? And we can go to an interactive slide. If you scan this QR code or go to menti.com and plug this in, I'll do the same so I know where. We'll give you guys a couple more minutes to, everybody got theirs in. There's still some struggling. You can go to menti.com and type in the numbers if you're struggling. We'll give you guys another 10 seconds or so. And so we've got a little bit of a range here, right? I want you to look through it. Looks like the majority of people are prescribing less than 10, which is what the current guidelines recommend. There are some people who are prescribing a little bit more than 10. And so if you can go back to my presentation, I have 3 objectives today. As I talk here today, I want you to think about your prescribing and where you answered on that. We're going to talk a lot about multimodal pain management strategies for our patients that are opioid sparing. And then I'm going to end it with a little bit of a challenge. So first of all, I want to thank Clayton, my co-chair, and the rest of the team. I've borrowed some of their slides, but this takes an incredible team. We've worked together for 6 years. Initially, we met every month or every other month. Now we meet once a quarter, but it's taken a lot of work. And the goal of the task force was to initially analyze what we're doing, but actually to have some impact on change. And so initially, we were studying and collecting data only. We had an intervention in 2019 that I'll talk about, and we've had a lot of publications since. And I'm hoping that I can persuade you to shift the graphs that we saw earlier today. So this is the data that we presented in 2019 to the cohort at the ACHQC Summit. In orange are the number of tablets that were prescribed by surgeons for inguinal hernia, similar to what I showed you. And on the left is what our patients were taking. The data that you all participated in shows a much better prescribing pattern than what this graph shows, which means we've had an impact over the last 5 years. This is what it looks like for laparoscopic hernias, and this is what it looked like for incisional hernias. Incisional hernias work very differently than ambulatory inguinal hernia patients. So our intervention in 2019, when I showed those graphs, were multifactorial. We challenged our surgeons to prescribe no more than 10 because our patients weren't taking more than 10. We had educational programs where we partnered with Michigan Open to provide patient education brochures every time we prescribed opioids, so patients would know what to do with their leftovers. And it also talked a lot about multimodal nonsteroidals, acetaminophen, pain medication regimen. And Todd Harris, one of our private practice surgeons who's facile at YouTube, created educational videos for our surgeons. We created a handout that went both to patients and surgeons, talking about Tylenol, Motrin, ice, and using oxycodone only as a rescue medicine. And then we followed it up and looked at what we were doing 2 years later. And we had a slight shift. We went from 10.6 to 8.8 for the mean number of tablets prescribed. Overall, there were less patients who were taking any opioids and were prescribed no opioids. So we moved the dial a little bit in 2 years, but not a ton. So we wanted to see what were the factors that were influencing both our surgeons and our patients. And not surprisingly, we wanted to look at the predictors of what patients take more than 10 tablets. And it's the smokers, it's the sicker patients, it's the patient open versus lap. But if you look at the arrow, the biggest factor was surgeon prescribing. Okay, the biggest factor was our prescribing habits, not our patients. And the inverse was also true for the patients who didn't take any opioids. The less we prescribed, the less patients took. Everything else being equal. This was the number 2 factor, the preoperative opioid use was a bigger predictor than surgeon prescribing, which is not surprising to any of us. But surgeon prescribing, again, is the biggest factor of what our patients do post-op. To take that a step further, Jeremy Warren and his group looked at Robaxin, methylcarbamol use post-operatively in both ventral and inguinal and showed a reduction in opioid use. And then Clayton has taken this to the next level. I think all of us fear that our patients are going to have a poor post-operative pain management outcome if we don't prescribe them opioids. We fear that they're going to be in pain, they're going to call us upset and unhappy with their pain control. And so we wanted to look at, and Clayton really initiated this, looking at whether patients do better with no opioid prescribing or 5 tablets prescribing. The aim of the study and really the hypothesis is that there's not going to be any significant difference between groups of patients who are randomized. And the way it's done, and I'm not participating yet because I'm private practice, it's hard to get IRB approval, but patients are randomized in the operating room to get a prescription or not. And then if they call at any point after surgery to get a prescription, it's considered a refill. I don't know how well we're doing with accruing patients. You can probably comment. And the goal is 1,000? 900. So halfway there. We'll get there. So in summary, I hope I've shown you that surgeon prescribing really relates the most closely to surgeon consumption. I think we've come a long way from 2019. I showed you some bar graph. Our bar graph today, what people answered, is significantly better than what really motivated surgeons were doing 5 years ago. But I think there's more work to be done. Really, patient education, setting expectation, and multimodal treatment plans work. They work really well. Further study is clearly necessary. But hopefully you believe that 5 tablets is enough. And so I want you to think about, after leaving today, are you willing to either selectively prescribe or prescribe less than 5 tablets or less for your routine ambulatory inguinal hernia patients? And if you are, we got another QR code for you. We had some technology. I want to thank Lauren in the back who created some slides for us since the one I did didn't work. So if you go ahead and scan, I want to see if you're willing to commit to either no prescribing, selective prescribing, less than 5. And if you're not, if you're still going to be doing 10 or more or up to 10, go ahead and answer that. For outpatient ambulatory inguinal hernia surgery.
Dr. Reinhorn, a little plug here. In 2019, I took the challenge. I was a previous opioid overprescriber. I'm happy to say for the last 18 months, I prescribed 0 opioids to outpatient surgeries, inguinal ventral outpatient in narcotic naive patients. I was very, very skeptical, but you all can do it too.
Lauren, I think that maybe it's the same QR code. Is it, people are getting the same question they got before? I don't know if it. See, if not, raise your hand if you're willing to go there. We'll just take a. Is there anyone, we've got a couple minutes left. Is there anyone here who feels like they don't have enough data and they still need to prescribe 10 or more tablets here?
My surgeons give 40, and I'm trying to do as well. And no offense, but to be proud of not getting it, because I don't have the data, you should show me data on both out. So I'm not with all.
Do you guys use, so I'm going to put a plug in for the QC. So in the QC, one of the advantages of our database is we've looked at how many tablets the patients actually took. And when we gave our task force member their individual reports, and it was astounding that I was overprescribing. I went from 12 to 6, and when I went to 6, I was still overprescribing, it turned out. So looking my own data for me made the biggest difference. So are you participating in a? Yeah. Yep. Well, I'll put a plug in. I think you guys are going live with the QC at the end of this month, thanks to Megan. So I'll stop with that. Thank you.
Okay, next up is Dr. Collins from Ohio State University. She's going to be talking about understanding the interplay of healthcare inequities and hernia surgery outcomes. What can we do to optimize patient outcomes?
Hi, everybody. Thank you for letting me talk about health equity, which I think is very important. I want to say you might find this talk a little bit maddeningly unspecific, and it's because I think we don't really have a great answer to this question, honestly. What I really want to do today is just talk to you a little bit about how to think about data in the health equity space, sort of borrowing some of the work that we've done in some of our other national efforts with the American College of Surgeons and that sort of thing. So I got to get a new joke for my first slide, but this is the last time. So, as we've all heard, we're all told when we're children that money doesn't really matter, right? But we know that in healthcare, it really does. Everything gets better when you have more money. You live in nicer houses, you go to nicer schools, and I mean, you even eat better food. We have talked a lot about food deserts for people who are in a low disadvantaged socioeconomic brackets. But today we're talking mostly about, what healthcare looks like when you come from certain backgrounds. And the thing is, it isn't really just about money. It's not that your bank account itself that's going to confer better health outcomes. It's about the world and the spaces in which you move and how you interact with the world around you. So people from certain racial, ethnic, and demographic groups have a lack of access to healthcare. Even when they get there, they might have low health literacy or significant language barriers that make understanding and making decisions a lot more difficult. There's also logistical challenges. It is very easy for me to take a day off of work, sorry, Ben, and get in my Subaru Forester and drive to the doctor. It is very hard for someone to take 2 buses off of an hourly job where they don't have time off. There's occupational barriers. Even if they can't get the time off, they have to do heavy lifting, and taking 8 weeks off to recover from a hernia repair may not be something that's feasible for them. There's significant resource allocation issues. These patients tend to go to, safety net hospitals that don't have the same technology or, staffing that other hospitals have. And then there's a physician bias. How many of our patients are labeled as non-compliant because they're late to appointments or miss appointments entirely for all the reasons that I just mentioned? We tend to treat these patients differently. We joke about the wallet biopsy, but we all know that's a real thing out in the world. And the thing is, it's never just one of these things. It becomes this sort of complex web of everything sort of interacting on each other. You're labeled non-compliant, so you don't want to go to the doctor. Once you do, you don't understand, so you don't go to your next appointment, so you're late. It all keeps spiraling into a vortex. And so what does this mean for hernia patients? And so this is some of the work that we've done. People from disadvantaged backgrounds are more likely to show up emergently. Once they're there, they tend to be farther along in their hernia disease process, so they have worse pathology, which leads to much more complicated cases and worse outcomes. These tend to be emergent surgeries. They tend to have, higher rates of complication, including death. And the thing is, they're also more likely to use the ER as their primary care office. So they're twice as likely to be seen in the ER for non-emergent hernia repairs. And these guys come a lot. You've seen this. They come and they come and they come and they come, and they keep getting sent home. And then they get sent to outpatient follow-up. And I love that our ER is the Abercrombie & Fitch ER, so I'm never going to get rid of this. This is true. This is true. This is an actual picture of the Ohio State Emergency Department. Anyway, yeah, it's Ben. So we like to think that you show up to the Abercrombie & Fitch ER at the Ohio State, and you get a hernia, and you get evaluated by a hernia surgeon, and you go right to this ER with our fancy robots where we're going to fix you up. But that's not really what it looks like, right? It looks a lot more like this. You get sent home, and you have to go to an appointment, which I mentioned is harder for certain people to get to. You have to be able to pay for it. You have to have insurance or time off of work. And then let's not even getting into comorbidities. But people from certain backgrounds are more likely to be obese or smokers unable to quit, and have comorbidities that are not well managed. So this is, and that's even for people who are offered surgery. And we have shown that you are much less likely to offer a patient who's not insured or underinsured surgery versus someone who's well insured. So this is the classic leaky pipe scenario. There are so many places where these people can fall off of our radar, and they're not able to get back on because of all of the barriers that they face. So this is all very sad. So I'm trying to lighten it up a little bit. So it's messy, and so that's why I'm telling you I don't have a really straightforward answer to this, but I think we can talk about how to think about it. So what can you do? Well, first of all, this is the first thing, is that we have to stop describing it. We love to write papers where we look at, the outcomes of Black versus white, poor versus rich, English speaking versus non, and we get some beautiful p-value and we write this paper. I do this. I'm guilty of this. I'm doing it right now. And we're like, look at this. Someone should do something, and then we leave the room, and so we have to get beyond this phase of just describing it and writing papers that have statistical significance and start looking on the ground at what you can do in your own communities. And I think it starts with identifying points of intervention. That's why I'm saying this is non-specific. It's because my leaky pipeline is going to look different from yours. So I can't say definitively that this certain thing is going to help you at your hospital. You really have to look at what the barriers are in your own communities. And I think this is really what I want to encourage you to do, is to really meet patients where they are and appreciate the world in which they're living in, and maybe redefine what your definition of risk and success is. And remember that web that they live in. When they leave the office, some patients are going to a completely different world than the patient after them. So this is an example of how I've started to rethink about this. So as there's these beautiful Delphi things that recommend that you have to be, fairly skinny in American terms, and not a non-smoker and have diabetes that's well managed in order to get a hernia repair. And a lot of people sort of live and die by this. If you don't meet certainly at least one of them, but all three, you're done. That's it. Like good luck. But the data on this, and this is from NSQIP as well as us, is that it's really not as important as we think. Yeah, complications do rise as BMI gets higher, but the overall complication rate is pretty low, and it gets close to zero when you look at laparoscopic repairs. And what about smoking? Cleveland Clinic loves to talk about smoking, so you guys are on here, don't worry. Looking at smokers, yeah, you do have a higher odds of complication in smokers, but if you look more, historical smokers will always have an increased rate of complications, even if they stop smoking. So really, what's the point of making people quit if they're still going to have a retained higher risk? And then some centers have documented that actually in patients who are well selected and have good perioperative care, this difference actually goes away. So looking at this through an equity lens, if you compare our elective hernia patients, just the table 1 to a trauma ACS hernia paper, look how different those demographics are. Our table 1 tends to have more white, male, well-off patients than a trauma ACS patient paper. And the thing is, women and racial minorities are significantly less likely to meet cutoffs for surgery. And this is, I could go on and on for days about BMI, how BMI isn't really made for women. It's not made for people who carry their weight differently. We are less likely to be able to meet those cutoffs in the first place. And like I mentioned, low SES patients in particular have barriers to optimization. A great example is Ozempic, right? There is not a rich white woman in Ohio who isn't getting Ozempic compounded for her for $1,000 a month, right? That is not an option for our patients who are uninsured or underinsured, and that's a significant issue. We are essentially asking patients to clear bars that really they can't beat. And then the important thing is, are we really looking at the right comparison group? When you're talking about risk, do you really want to be comparing the non-optimized people just to the optimized elective patients? Well, how bad did they do when they show up in the ER emergently? Like that's really the other group that we don't really see in our databases, including the QC. So I want to talk a little bit about metrics. This is a great book about the tyranny of metrics. And we are all so obsessed with this is a good hospital, by the way. This is low complication rate. We all get our QC folder and we want to be at the very end. And we become sort of enslaved to it. Like we can't do anything that's going to move it even 1 percentage point up, because then we move so far up the curve. And that is important. But I think when we look just at that, we sort of lose context. We forget that by kicking those people out of the office, we're potentially shuttling them into a trauma ACS situation, which is going to be even worse. So this is how I frame the conversation with my patient, or how I talk to them about it and how I think about it in the office. Looking at them right now, can we do better? If you smoke 2 packs of cigarettes a day, can we get you down to a half? Your BMI is 45, but was it 50 a year ago? 45 might be pretty good. That may be the best they're ever going to get. And what do you want to do with that information? So again, what's good enough? If they're losing weight, but they plateaued at 42, you're really not going to operate on them. Like, what if they lost 150 pounds? That context is important here. On the other hand, if 6 months ago they were BMI of 32, that shows you maybe you have some room to go. What is the actual risk of operating? And so this is where you want to get out your complication score, of whichever one you want to choose, and look at what the actual risk of operating on and what complication you're preventing, and balance that against what the risk of not operating is. Is this person in the ER all the time with bowel obstructions? Are they headed for a hernia emergency? Now, these questions are both important, right? Because we don't want to just say, oh, everyone can get surgery, it's fine, complications don't matter. But I think you have to weigh these things equally, and look at the whole context of the patient. And the last 2 things are the most important is do not just send people out of your office and be like, go away, stop smoking, lose weight. If everyone could be skinny, we would all be skinny. If people could stop smoking, they would do it. It's expensive. You have to figure out what resources are around and offer them a way out, because, if they could have done it on their own, they would have done it by now. And the last thing is what's important to the patient. And I talk to them about this a lot. I'm like, listen, you are a higher than average surgical risk for what you have. And we show them a little bar, I am willing to do this for you, but you need to understand that you could have a complication. Is it worth it to you, or do you want to work with me for 6 months and try and minimize this and get your risk down to here? This is a really important back and forth conversation. I think kind of brings the patient along with you, makes them feel like you're on their side. You'll actually be surprised how many people say they want to try. So going back, the last thing I want to talk about is data, and just again, how enslaved we are to this idea of being in that top percentile. So how do you actually look at your data? First of all, are you asking the right question? And I'm going to, spoiler alert, the right question is not, do white patients do better than Black patients? Do rich patients do better than poor patients? That can't be your only question. The question is why. where along that pipeline are you going to intervene? And so you want to keep that in mind and analyze your pipeline and figure out what point of intervention you're hoping to address. And so in that sense, are you measuring the right outcome? Is seroma formation the outcome that's the most important to your patient population? It may be, but it may not be. It may be ER visits, maybe time back to work, that sort of thing. And are you capturing the right population? I use the example of my hometown a lot. I grew up, and I joke that I didn't see color growing up because there literally were no non-white people in my hometown. I didn't see one. But there was a really big Russian Orthodox population, but they're getting folded into the white outcomes here. I have to believe they had a different experience because they didn't speak English. They hardly ever came into the main town. There was a lot of distrust in between us. So I have to believe that if I would go back now and look at their outcomes, they were probably different, but we didn't think to look for it. And then is your sample size adequate? We think about this a lot with the QC data. There are just some groups that are underrepresented. So not seeing a different in that group doesn't mean it's not there. It may just mean you're not capturing it. And that's a really important limitation to think about. And the last thing is, what are you going to do with the results? And so and it starts with knowing how to interpret it. This is a graph of US deaths since 1950. And you look at this and you're like, wow, we're so great. Like, look at us. Like, look at heart disease going down. Cancer is about the same because cancer sucks. Strokes going down. This doesn't show that if you're an African-American male, you're actually slightly more likely to die of a heart attack than you were in the 80s. And then we have a skyrocketing rate of stroke deaths for Latinos, especially women, that's unexplained. That's hidden by these data. And so it's important when you get your data reports back that you know how to interpret it and you know what to look for, and you're not letting sort of the signal drown out noise and not letting the bigger groups drown out the effects on smaller groups. So one last thing. It's election time. Okay. And I say, I want to say that just as an Ohio person, no one has tried to eat my cat. And that's all I'm going to say about it that I know of. What am I? Anyway, and the reason why I bring this up, I know that's, is just because anything with the letters D, E, or I is getting very controversial in this country. And I'm not here to defend DEI hiring practices or anything. But what I really want to emphasize is this rhetoric gets very vitriolic and everyone gets very worked up about these sort of racial ethnic differences that may or may not exist, is that in the patient-facing space, this is still very important. I would actually argue that it's crucial. And I don't just mean from a moral standpoint. It's actually, I can back this up. Both the Joint Commission has instituted standards around health equity. CMS just launched a 10-year plan to reduce disparities in certain demographic groups, including how to analyze your data when you report it to them. ACGME just renewed their requirement that residents be trained in how to address healthcare disparities and treat patients from different cultures. And the American College of Surgeons is instituting requirements around health equity and access to care in their quality programs. So, I don't want the rhetoric to get away from us as it kind of gets very political out there. And again, the DEI words get very, controversial. This is still something that is really baked into the American healthcare system, and so should be baked into all of the work that we do. So my charge to you, I guess, is to think about your own leaky pipeline. Again, I can't tell you how to fix it, but it's important to look on the ground and maybe pull back from some of these big national studies that are already been describing problems that we know exist, and find one or two places where you can intervene kind of in your home institution. And it's going to look different for all of us. Thank you for listening. I need a picture of the new hospital, but and I will look forward to questions at the end.
Okay, next up from the other institution in Ohio, Dr. Betha from Cleveland Clinic, heavyweight mesh in contaminated fields, risk benefit of pushing the limits.
Thank you. And I would like to say, I would like to propose a new, maybe randomized trial of comparing the number of ER visits with and without bin out front of the ER door, and just see what actually, are you drawing people in bin, or are they staying away because of you? So we'll have to do a deeper dive into that. Okay. I'm Luke Beffa, and I'm at the clinic, and we'll talk about heavyweight mesh. I just wanted to also briefly say how great it is to be involved with such a great group at the QC, and to everyone in this room who really appreciates evidence-based practices. So I think that's just, I'm just honored to be a very, very small part of that. I don't have any disclosures. So heavyweight mesh and contaminated fields Why is this even a thing is kind of what I wanted to address first, because probably most people think contaminated settings, you shouldn't be using mesh anyways. And now you're talking about the heaviest, most densest piece of plastic we can put in people at the same time as a contaminated surgery. So why is this even a thing? And how we got to that, I did come up with a little bit of an algorithm of which is evidence-based that hopefully can guide a little bit of this, and then a quick summary. So everyone knows there's 4 classes of wounds. And when you get into an elective hernia repair of a CDC class 1, a clean case, which is the vast majority of what you probably do on a day-to-day basis, you're going to do whatever you do best, whether that's an external oblique release, an onlay, whatever mesh of your choice, whatever it is that you give the best patient best outcome, you're going to do that. And that's great. On the other side of that, on a CDC-4, where there's gross contamination, there's stool everywhere, you are not going to probably be putting a lot of pieces of mesh in that situation, and you're going to be primarily closing that hernia. And if you can't, our preference is to kind of bridge that gap with an inlay of absorbable mesh of your choice of probably what is be the most cost effective. But that remains in the middle here of CDC 2 and 3. In those cases, what the heck do you do? And it is not clear cut. I'm just going to spoiler alert, it is difficult to decide, but hopefully I can give you some answers there. So at least in my operating room, I think of it, and everyone has kind of plan A, there's plan B, and there's plan C. But it doesn't always go that way. And for me, sometimes it's more like this, where it's like, okay, I started plan A, holy crap, I divided the ureter, it has to be reimplanted into the bladder. Geez, maybe we should go to plan C. And then we're like, well, then maybe that anastomosis went a little better than I thought. Like, let's meander back to plan A maybe. So at least for me, it isn't as quite forward. Everyone likes to think that way, but it isn't. And just acknowledging that is important. And I love this quote by Mike Tyson, because I think it's very adequate to what happens in the operating room, because no one anticipates getting a contaminated cases. Very rarely do you do, but everyone's got a plan until you get punched in the face. And being in a contaminated setting that you don't anticipate is like being punched in the face by Mike Tyson. I just wanted to quickly put this out there. I think this is an absolutely fantastic article, and if you have a chance to read it, it goes through a lot of the decision making here. It's written by Clay and Mike. I think it's just really, really well worded, and if you have the chance to do it, it goes through some of this as well. Okay, so how do we even get to contaminated mesh and putting mesh in contaminated settings? Well, there's kind of 4 major progressions of studies, and to be honest with you, there's way more than this. But Alfie kind of introduced this, and it was very controversial at the time back in 2013, where he did 100 patients, open ventral hernia repairs with lightweight polypropylene mesh in CDC 2 and 3 wounds. And that kind of started the whole progression here. And his outcomes there were actually not bad. SSI rate of 7.1% in CDC 2, and the 3 wounds, he had a slightly higher rate, as you would expect, 19%. Again, not horrible. And 4 patients did have that mesh removed, but none of those patients had mesh removed for infections. So that's kind of interesting. Probably not what he thought he was going to find, but nonetheless, it's compelling. 3 years later, Mahumder did 126, this is retrospective, biologic versus synthetic mesh in CDC 2 and 3 wounds. Again, not maybe what people thought they would find, but a lower SSI rate in synthetic mesh and less recurrences in synthetic mesh. Adds a little bit more to the data. Jeremy in 2020, 541 patients, by far the largest retrospective trial looking at this. Medium weight, permanent synthetic mesh, biologic mesh, and absorbable synthetic mesh. All 3 different class types. He even included CDC class 4 wounds. So he went from CDC 2 to 4. And what he found was just like the previous trials, permanent synthetic mesh had the lowest SSI rate, 14%. Biologic mesh, 37%. Absorbable synthetic mesh, 33%. The recurrence, also the lowest in synthetic, 10% versus 26 versus 30%, with a mean follow-up of 55 months and no difference in mesh removals. Now, that is something to hang your hat on potentially. And then the limitations with all of those is that they are all retrospective in nature and subject to selection bias. So what Mike did was he said, let's do a randomized trial. 253 patients, randomized trial, comparing medium weight synthetic to biologic mesh. CDC 2 and 3 wounds only. And what he found was just like the previous retrospective trials have found, no difference in SSI rates, and the recurrence rate was much lower in synthetic mesh versus biologic. So that's all pretty compelling for synthetic mesh in contaminated settings. But to keep in mind, a lot of that was retrospective and all of that was medium weight polypropylene, except for the first study, which is lightweight. So in our practice, we started noticing that medium weight mesh was breaking and at a rate which is relatively low, 4% of all comers. But when you do between 600 and 800 of these a year, that's about 20 people a year. That's more than one a month that's breaking. And that's pretty disheartening after doing a huge open tar. And then people come back with occurrences and you've burned your best bridge to repair it. And if you look at just the people who we couldn't close the fascia and they had medium weight mesh as a bridge repair, a third of those patients were recurring. Now, luckily for us, that's pretty rare. We can't close a fascia, but that's a pretty significant number. And a third in a bridge repair for medium weight mesh, that's unacceptable. So just like Charles Darwin, he said, it's not the strongest species that survived, nor the most intelligent. It's the one that is the most adaptable to change, that lives within the means available and works cooperatively amongst common threats. So just like Charles Darwin, we adapted and we changed. So we took that data with a break and we said, well, now that's going to lead us to heavyweight mesh. But wait a minute. All of the contaminated mesh studies were all in medium weight stuff. So how does heavyweight perform in contaminated settings? Before we did that, though, we wanted to compare heavyweight versus medium weight. And we did that with a randomized trial of 350 people, CDC. These were clean cases only, but we first wanted to make sure that heavyweight wasn't any different than medium weight to begin with. We did define heavyweight mesh as greater than 75 grams, which is, to be honest with you, on the lower end of that. But that's how we defined it. We looked at pain, quality of life, recurrence 30 days, absolutely no difference. And then at 1 year, we asked people, can you feel your mesh? And there was absolutely no difference. 19% versus 18% said they could feel it. So all of that, but that was in a CDC class 1. So what about in contaminated mesh and settings, can we use heavyweight mesh? And that's all of that data kind of led to this moment. And so we designed a QC query. We looked at CDC 2 and 3 wounds, where we did open retromuscular repairs and 30-day outcomes comparing heavyweight and medium weight mesh in that setting. There's 351 patients versus 117 in heavyweight. And we did a propensity score matching. Importantly, we did not use any flanks. A lot of these were peristomals, however, and this is just the data, I know it's a lot, but a couple of things I just want to point out. One is that 15% of these contaminations came from intraoperative complications. That's quite a bit. There was 16% of the heavyweight mesh was used in peristomals, which is also somewhat controversial as almost every peristomal paper you read uses medium weight mesh. And then lastly, just pointing out, the median hernia width is 14 centimeters. So these are big, complicated hernias of which we're getting contamination on. So what did we find the difference? Anybody want to guess? No difference. 30-day outcomes, we had nobody recur. SSI rate was exactly the same. SSOs, SSOPIs, reoperations, and readmissions were absolutely no different. So that led us to conclude that heavyweight mesh in open retromuscular hernia repairs seems to be relatively equivalent to the outcomes of medium weight polypropylene. Now that's 30-day outcomes, so you can argue that 90 days might be better for that type of stuff. What does 1 year show? That data will come. But as of 30 days outcomes, it's not any worse than medium weight. So I came up with this proposed algorithm. Welcome to use it. It's very simple. But if you start with the retromuscular hernia repair and you have a CDC-1 class, you're going to do whatever you do best. And if you go to the other side of that algorithm, CDC-4 class, suture only versus absorbable inlay. But what I wanted to focus on was the 2s and 3s. My next question is, can you close the fascia if you have a CDC 2 and 3? If the answer is yes, I would probably argue with you that there is still more data for medium weight mesh in that setting. And with the closed fascia, I would probably take a 4% mesh fracture rate if I was in the general population. We do tend to use heavyweight mesh in that setting, but there is probably not much difference between that and heavy and medium weight. If you can't close the fascia in a CDC 2 and 3, I would consider using heavyweight polypropylene. All right, so clean contaminated hernia repairs, they're tough, they're difficult. It's still not clear cut for sure, but this is a little bit of data around it. Retromuscular polypropylene mesh does have data to support its use in contaminated settings, so don't be afraid of that. And significantly other trials as well over decades. And I would consider using heavyweight polypropylene in CDC 2 and 3 class wounds where you can't close the fascia. Thanks, and looking forward to you guys' questions.
Okay, last talk is by Dr. Lima. He's at Monty in New York, and he's gonna be talking about what are the incisional hernia trends, real world data over 9 years from the ACHQC database.
Hello, everyone. So good to be back and to see you all. My name is Diego Lima. I'm from Montefiore. I'm a PGY3. Today, we're going to talk about the trends in incisional hernia using the QC database. We have no official disclosure. So we know that in the 90s, LeBlanc developed minimally invasive repairs for ventral hernias, and we started with IPONs, mesh stack sutures that were in contact with fissura. This could lead to complications. And then we had the development of new MIS techniques. We have the preperitoneal, the heteromuscular, different platforms now with the robots, different robots coming, most recently, different mesh positioning, access techniques, need for TAR, myofascial release, and different types of mesh. And our colleague here, Dr. Almansu, he published recently the trends in minimally invasive repair for small ventral hernias from 2012 to 2021. Hernias smaller or equal to 6 centimeter, and we see the increased proportion of the preperitoneal heteromuscular repair over time from 10 to 53%. Robotic, in the robotic group, more than 85% were preperitoneal heteromuscular with IPON only 47. And the heteromuscular repair with a high risk of 30-day reoperation and readmission. You can see in this graph, like the increase in the heteromuscular and the preperitoneal repairs over time and the decrease of the IPONs over time. And our friends from Europe, they also published the trends now in only incisional hernias from 2010 to 2019, with increase in the open sublate repairs, MIS sublate, like the other study, also heteromuscular preperitoneal from 4.5 to 10%, and the decrease in the lap IPON from 33 to 21%. So the objective of this study was to evaluate the trends here in the States using the QC database in the last 9 years. So we had adult patients with only incisional ventral hernia repair, no lumbar hernias, no concomitant inguinals, robotic laparoscopy and open with 30-day follow-up, clean or clean contaminated wound class, mesh use permanent synthetic or resorbable, not biologic, and elective cases. So we start with 125,000 patients. After applying our inclusion criteria, we ended up with 17,000 patients. And we divided these patients in 4 groups according to the time frame, 2013 to 15, 16 to 18, 19 to 2021, and 2021, 2020, actually 2022 to 2023, I'm sorry. When we look at the demographics, there were no difference between these groups, and we had in all cohorts we had like female of 55%, very similar, with median BMI also similar across the 4 groups, 32, and the age, the median age was increasing over time to 60 in the last cohort, more recent cohort complete group compared to the first cohort, 58. The most common comorbidities that we find in these 4 groups were hypertension, diabetes, use of antiplatelet coagulation, and we had an increase in current smokers from 4 to 4% in the 2013 to 2015 to 10% in 2022, 2023. And surgery was across all the groups, mostly performed in academic centers. When we look at the perioperative characteristics for these groups, we see that tap block became more common over time, especially 19 to 2023. And you can also see that over time, the hernia length and hernia width was the median was increasing as as well, with also an increase in the mesh size used over time. Permanent synthetic mesh was most used in all groups. And fixation, you see that the suture was also the most used in the four groups. And this is a very interesting graph showing over time the increase in the robotic approach and the decrease in the lab and in the open. And when we come to the last group, we have more robotic cases than open cases, which I found to be really interesting data. And when we look at the mesh positioning, we see that the sublay was the most used in all the groups. And when we look at the sublay position, we see an increase in the heteromuscular repair and a decrease in the intraperitoneal repair over time. And when we look at also the component separation and fascial closure, we see an increase in the fascial closure over time, and an increase also in TAR over time, but not, over time also as well. And for postoperative outcomes, we see decrease in readmission, interesting decrease length of stay, no difference in reoperation. We see like kind of there's no clinical significance when you look at the SSI, it's 3% for all groups. And we see also for four groups varying the SSO, seroma, and SSO-PI are gonna go for the, I'm gonna take a look at the logistic regressions for these. When we look at the logistic regression for 30 days readmissions, we see that the heteromuscular repair was associated with higher likelihood of readmission, and also the onlay repair compare to the sublay repair. When you look at the groups in the graph, like according to the year of the operation, there was no difference in this in the groups. That's the same. So surgical site infection, also we see that the heteromuscular repair was associated with higher likelihood of having surgical site infection when compared to the other mesh positionings. But when we look also at the years, since we are evaluating trends, we see no difference between the groups, and increased risk with the increased with BMI and with diabetes. For surgical site occurrence, we see the same trends, like for Dr. Olmos also found in his study, like increased some complications with the heteromuscular repair, and also with the and we found with also onlay versus the sublay. And if you look at the length of stay, we can see in the year of operation kind of a trend and going down when you compare most recent years, and this could be associated also with the use of the robot, because we're now sending patients from PACU instead of staying like 3 days with a large incision in their belly. Obviously, this study has limitations, retrospective data. We have performance bias. We know that this data comes from surgeons. They are more interested in doing a wall reconstruction. This is a voluntary input of data by the surgeons. And our conclusions is basically that there is a significant trend towards doing MIS repairs for incisional hernias. And this trend is accompanied by this low intraoperative complications. We are using bigger meshes for larger defects, which supports the hypothesis that we are improving patient outcomes over time. Thank you so much for your time. It's a pleasure to be here to see you all, and I'll take any questions.
Oh. We have about 15 minutes now to ask some questions. I'm going to invite people up to the microphone, please.
Hey, Katie Schlosser. I'm at Beth Israel Plymouth. I have a question for Dr. Beffa regarding medium weight and heavyweight mesh. A lot of the studies that we have show that there's a lot more difficulty in clearing infection from heavyweight mesh when compared to medium weight. Does that change your algorithm when you have a patient who had a heavyweight mesh placed? How are you going to try fewer times to clear something? Are you going to debride sooner? How do you manage that potential infection in those patients?
Yeah, great question. I would say that a lot of those bacterial clearance studies were performed in vitro. And so taking a mesh construct and dipping it into like whatever and then determining factors clearance is probably not as pragmatic or real world as putting something against a relatively well vascularized retromuscular space. So to me, I think it's a little bit more important about what the clinical outcomes are for those in the human body as it stands. It's obviously a concern. I mean, don't get me wrong. It wasn't like we came to use heavyweight mesh and contaminated seasons. Like one day we're like, let's do it. Yeah, we were seeing problems and we wanted to, like Charles Darwin, you got to continue to change, adapt, and try to find solutions to those problems. So, we came up with this, but we really didn't know if it was safe at all. I mean, and that's part of pushing the edge and kind of where we're at in our practice. And so as we were doing it, we were like, doing a randomized trial in that setting, just to let everyone know, is probably not really doable. I mean, that's a huge IDE, FDA regulated trial. And so that's the power of the QC, is that you can get those answers without having to do all that stuff, or at least as close to some of the answers you can. Now, don't get me wrong, 100 patients or 300 patients is not a lot, but at least it's something that no one's really looked at before. Would I get an infection? I don't do, I mean, as far as like, if I get infected medium weight versus infected heavyweight, absolutely nothing. I don't do anything different at all. And just, our practice for that is, I mean, obviously if the patient's super, super sick, you got to take them back to Alpert and do something. But if it's just, you're staring at your mesh, maybe 2 or 3 weeks later from an open wound, oftentimes local wound care, packing, wound vac, whatever you want to use, that will most of the time granulate over that mesh. Now, you can oftentimes, if that doesn't work, you can oftentimes get them down to like a pinpoint wound, and then you just take them back maybe 6 months later, and you can just take out a little bit of unincorporated mesh. And what happens after that is a different story. But at least the times when you're seeing your mesh and you have to explant the entire thing, I think those days for at least open retromuscular surgery, that's antiquated.
I have 2 questions for Dr. Petro. Okay, first question. Let's say moderately symptomatic peristomal hernia, bulge, pain, but no bowel obstructions, no pouching difficulties, big enough that they need a retromuscular repair. When you talk to these patients, are you kind of like, oh, we have this great option for you, you should have surgery? Or are you kind of like, I would really only go for it if it's symptomatic enough? Is my first question. And then my second question is, if you say to them, okay, this is the option that we have, it's a retromuscular repair, the recurrence rate is 21% or whatever you said it was, how many of those 21% actually need something done about it? Like, what do I tell my patients?
Okay. So the best answer, usually by the time people show up in our clinic, they've already gone back to whoever gave them the stoma, which tends not to be us, and they have lived with it for a while. So typically by the time they come, they have a pretty good idea themselves of whether or not they want it fixed. But in the scenario you described, I think what's really helpful, if you look at the post hoc analysis that Ben wrote up for the peristomal patients in the biologic synthetic trial, there is no question that there's an improvement in quality of life, both on the Hercules and the SF-36. And so what you can see on those scores is they start at like, for the SF, I can't remember off the top of my head, it's like 0.7 and they go up to 0.9. So, I mean, if you ran into that scenario where someone was on the fence, you can give them a tool, see where they're at. If they're 0.9 pre-op, how much better can you make it? If they're 0.6, you can like tell them, like, I could probably make your quality of life better. And then the second, what was the other question? Oh, for the people, yeah, we had that. It's much fewer than that. And again, I think that, small peristomal hernia recurrences that without an obstruction, sometimes our quality of life again is such that they might not necessarily pursue unless they have like a pouching issue or something like that. Again, the patient will typically tell you, like, I can't think of many scenarios when we see a ton of these patients where we're sitting there going, oh, I don't know what to do. And then if you ever are in that scenario, you could say, all right, listen, if you're clearly unsure, why don't we take 6 weeks and come back and see me? And if you in that 6 weeks are like pulling your hair out, then we'll just go ahead and do it. Reoperation. Yeah, which is why the PROs are so important, because again, these are CT recurrences that don't necessarily require a reoperation.
Also for Dr. Petra, I guess, with the benefit of hindsight and seeing the results of study versus retromuscular Sugar-Baker versus keyhole, and knowing that both have a relatively similar recurrence rate after 2 years, do you or have you changed any of your practice for what you offer patients in terms of reciting keyhole repairs or trying to repair them in situ?
I'm not sure I entirely do you mean,
Sure.
does it impact my decision to take it down or not?
To take it down and recite in the same place or recite in a new location, if you were to do
Yeah.
a keyhole, knowing that their recurrence rates are similar to whether you would Sugar-Baker it.
Yeah. So it kind of, because I'm kind of agnostic more now to the technique, I do a little bit of a deep dive on like, okay, this is your chance. If you want to move it, like tell me now. We can have the stone person mark you. We can give a better idea. I make a big deal about this. I've heard other folks say it doesn't matter that much. I'm really like skeptical, like for the really big peristomal hernia, when that's all reduced, that skin is just going to be a deflated balloon and the pouching is going to be really hard. Heard others say they don't think it matters that much. To me, I think it's really nice. Like I love when a patient's like, nope, just move it. I love that because it's nothing better than starting at a brand new spot. I do get a little nervous when someone's like, oh no, I really like this spot, but it's a big peristomal hernia. I'm like, I don't know what it's going to look like when, 2 months later, like how's the dust going to settle? I do get a little nervous. So if there's any temptation to move it, I tend towards moving it.
Just a comment on my end. I mean, I think there's that delayed gratification piece from a surgeon, and it never looks great up front. But when you see them several months down the road, or you see them for an annual visit, I think it actually works out rather nicely, especially if you start to purse string the deep soft tissues in the skin, that you're able to really avoid those skin related complications that we all fear. And it's really not gratifying at all that first like 2 to 4
Yeah.
weeks if you look at it.
Exactly. Yeah. Anyone that's nervous about their pouching issues in the first like week, I just say, just give me like 2 months for the dust to settle before we start talking about like local revisions and things like that.
Another peristomal hernia question. So the 2-year results, not a difference in terms of recurrence, Sugar-Baker versus keyhole. Did you quantify like minutes of OR time? I wonder if there's a resource utilization argument towards keyhole in addition to just ease and technique, difficulty of technique and that sort of thing. Is there an argument that you shouldn't do it because it's going to add, time to the OR and, the resources, that sort of thing?
No, I don't think so. I think that the amount of time it takes to take a stoma down without compromising a lot of length is probably the amount of time that you add to a TAR. Like doing a TAR without taking a stoma down, I mean, that's tricky. I mean, you got to really like know where you are and keep things organized. And I think that's probably ends up being a wash. The OR times weren't different. Yeah.
Thank you. And then the other question is, in terms of that, do you think the patient-reported outcomes, the way that was asked, do you think that was able to capture the benefit of that additional year for those patients? That 1 year difference in recurrence between the two techniques, there's obviously a benefit for those people because they had an extra year of not having a recurrence, but would that have been able to be captured in that study?
So probably not, because there was such a small proportion of the total group. Don't forget the PRO data we showed was all the patients that had one technique or another. We didn't break it down by whether or not they had a recurrence or not. So we're doing a post hoc analysis now of technique of the recurrence stratification technique, and that will You know, you can only fit so much in one paper. And so now we're going to do the deep dive on the more subtle, differences in the sizes of the recurrence and the technique and how that impacts the PROs.
Okay, because it seems like that's the remaining benefit. It's that extra year.
Yeah.
From that data. set.
Yeah. If I could take a mulligan on anything, it would probably have been in the paper making a bigger deal about the year. Because I mean, at the
Yeah.
end of the day, like an extra year
Yeah.
without a recurrence, that's not nothing. So, yeah, I'll be curious to see what the PRO difference is in that year too.
Thank you.
Yep.
And don't forget that the PROs are, I mean, Hercules is now validated with peristomal hernias. So,
True.
so that is, it's not a stretch, but like there's something there. In the colostomy impact score, if you ever read it, it goes over things like, do you like the odor from your stoma? So like those things are inconsequential to hernia repair. So it isn't, the PROs aren't perfect and there isn't a great, this is the area of that we've been working on with Neil Smart about how to develop a quality of life specific to peristomal hernias that actually is validated in those patients because they have pouching. They're a different beast, as everyone knows, with recurrences. And so we really do need a peristomal specific quality of life to really kind of, I think, do a little bit better job of measuring it. I don't know.
Yeah, that tool is not even for peristomal hernias. It's just for folks with a colostomy after an APR specific. That's what it was validated for. So it's not even really for peristomal hernia patients. But it's so hard to do this.
Oh, thank you very much, Ali from the UK. Anecdotally, just a quick question to everybody. Do you actually change your gloves, whether religiously or cult following, prior to placing a mesh? And secondly, have you compared all of your data, particularly the heavyweight mesh data, with the hernia registry, which is, as you know, is the largest registry in the world? How does it compare? Have you found any differences?
Do you just want to go down the line and say, do you change your gloves before you?
Yeah, I do.
Yeah, I do too.
Yes.
No.
Interesting. So 2/3, 1/3, probably. 2/3 of us, I do. Does everybody else? And just show of hands. Does anybody else change the glove before they touch the mesh? Yeah, I would say. I mean, man, it's such a cheap intervention. And if you ever, and if you ever look at the packaging of your gloves, which you should read, there's actually a time limit how long they're supposed to be sterile. And for open TARs, you might surpass that time limit potentially. So it does make a little bit of sense. As far as your heavyweight versus medium weight, you saying, did we compare our registry data to other registry datas? Right. Well, I mean, I think the Danish registry has us killed with follow-up, first of all. I mean, geez, they just reported 100% follow-up. Like, what's our follow-up been, like 10%, 13, maybe at most? Yeah, I mean, it's 30% outcomes the QC is very, very good at. Don't get me wrong. And that's what we reported. Longer than that, though, it starts to drop off pretty quick if you look at some other trials with the QC. I think they've looked at it for the groin, but I don't think in the ventral hernia space that I know of the Danish registry looked at.
So do you think your data is comparable to their data as a benchmark? Do you think there's something extra that you've discovered that you could teach us?
I'm not as familiar with the Danish hernia registry, just of patients in general, because we don't query that. I would imagine our BMI would be slightly higher. Our average BMI would be slightly higher, and potentially our average hernia width would be maybe a little bit. I mean, 14-centimeter wide hernias are big hernias. But the Danish hernia registry might also have that exact same data. To be honest with you, I don't know if it's as big. Does anyone else have any clue? Will, do you have any? I don't think she's in here.
I think the point of looking into it is the idea that it's the weight of the mesh that is, when all this data came out about medium weight mesh polypropylene being able to be resilient in the presence of infection, a lot of that was touted to be due to the weight and the porosity. The animal data showed that Marlex, heavyweight Marlex for the rat, when we put it in rats and poured MRSA on it, did just as well. If it's in a well-vascularized plane, which is the retrorectus data, the data that was mentioned before about, the early 70s when they were putting it in bridging scenarios for guys that were coming back with an open abdomen from Vietnam, they were getting fistulas and chronic mesh infections. And that's when all this, that's the fear of heavyweight mesh that lasted a generation. But when modern retromuscular techniques are employed, you've got this huge well vascularized pocket, and you can probably put, you know, a big heavyweight piece in, and you're not going to get all those fears about heavyweight mesh from, you know, 50 years ago. So the idea that it's the weight and the porosity that is the secret thing, it's probably just that polypropylene is just really good. If you look at the original descriptions of polypropylene mesh in the 50s, they kept remarking on how impressed they were on its ability to clear an infection. And so that was way before, you know, macroporous medium weight mesh. So I don't think it has anything to do with the weight or the porosity. I think polypropylene is just really good at clearing infection.
I want to change things up a little bit. I have a question for Courtney. So a couple of sessions ago, I gave a talk on preoperative optimization, and I touched on disparities with optimization. And someone sitting here wrote a really good question, but then we ran out of time and they didn't ask it. So I want to ask you that question because I know my thoughts about it. But the question says, if we offer operations to, let's say, a morbidly obese Black woman from a poor background, wouldn't that introduce disparities in complications?
Well, I mean, I think it depends, right? You know, so it's like a lot of the data around optimization isn't actually as good as we think. We've in the QC shown that actually. So like, how obese is she? Is your BMI 60? Like, then yeah, you probably shouldn't do that. But if it's, again, at 42, like traditionally that's a cutoff, but that's probably that may be the best that this woman's going to get. I think it's a more fluid conversation, you know, and I think you have to sort of look at, you know, is the patient in front of you the best they're ever going to be? If the answer is no, and there's room to improve them, then I think you should do that. But I think a lot of times it's just really, you know, understanding again the world in which that patient moves, and remember that it's not just comparing optimized patients to non-optimized patients; it's also comparing emergent and non-emergent. I think that's the slice of the population that we tend to leave out when we're having these conversations. So I think it's not a straightforward answer. I think it's gonna be different for every surgeon. I think it's gonna be different for every patient.
I actually totally agree with you. I think actually the question says a non-optimized patient. So operating on non-optimized patients, and I don't think we should operate on non-optimized patients. I think we just need to revisit what optimization is. So if you try to hold that BMI of 60 to a BMI of 35 as your target, they're never going to get there. Our goal is to get everybody as optimized as they can possibly get, and then get them an operation. And when they get a complication, we shouldn't beat ourselves. We just need to treat them through the complication.
Yeah, I think the strict cutoff idea, that's what you're saying. Like the idea that, because this could easily get rebranded. I think folks hear this and this gets rebranded as us being irresponsible surgeons. And I think that really it's just the idea of strict cutoffs that we're getting away from.
Please.
Rich Pierce at Vanderbilt. I guess I don't think the infected mesh horse is quite dead, so I'll beat it a little bit more. The one thing that the QC does not capture, and I'm not sure how it's controlled for, is do people change their practices when they know that they're working in a contaminated scenario, i.e. more drain use or say use of postoperative antibiotics. I often do that if I don't want that mesh to get infected. And obviously the QC captures whether there's drains and whether they're against mesh, but it doesn't ever check on post-op antibiotic use in a contaminated scenario.
Yeah, interesting you bring that up because we're just now designing a randomized trial comparing duration of antibiotics after elective hernia repairs. I would say, you know, if you were going to extrapolate from other contaminated surgeries like emergency general surgery, I don't know if there's much evidence greater than 24 hours, but that's caveated a little bit by how bad the contamination, like if you have perforated appendicitis with fecal contamination, like that's like 3 days. So it's not quite as comparable, I don't think. But I would say that we don't capture well how the QC changes practices. I think I agree with that statement, but I think that's something that's that as we kind of go through the process of the QC, we have the meetings, the data gets put out there, we all talk. You know, all the surgeons get together and say, I do this, and this is the QC. I think that's something that is would be really great to see, which we do see some of it, but I don't think we capture it very well, which we should.
Pen?
Yeah, great talks, incredible topics. I want to make one point of clarification. QC does capture long-term follow-up. We don't have unlimited resources to do this all on 126,000 patients, but we have a specific focus on follow-up program where we're able to do focused follow-up on smaller populations. I was having a little bit of a moment back there because for all the fine topics that were discussed, we wouldn't be having this conversation if it weren't for a lot of groups coming together, collecting high quality data. And I want to kind of call out those groups here. First are our surgeons, the AHS, who actually gave us the initial chance with some seed funding a long time ago. And then all the teams that input data, our QC, a group that helps us on a day-to-day basis, keep the operations going for the collaborative. And then finally, I specifically want to call out our industry foundation partner, several of whom the representatives are in this room. This would not be happening if it was not for the investments made in the QC and the collaborative nature of what we do. So thank you, everybody.
Thank you, everyone, for a great session. Want to, again, recommend you come to our annual Quality Improvement Summit in 2025, February 22nd and 23rd. We'll have more topics on peristomal hernia. We can promise you more on heavyweight mesh and some flexibility with our pre-op optimization. I hope someone's on the phone.
Yeah.
My first day of residency in 2007, I was told everybody gets 40%.
And one of it was one of the things because I they are